All right. I think we're live. Push 1 in the chat if you can hear me. All right, got a confirmation. Thank you for that confirmation. Welcome back to the Black Brain Trust. This is episode 812, Black Healthcare Talk. Please hit the like button as you come in, share the video if possible, and hit that notification bell so you get all the updates from the Black Brain Trust. There's a doc in the description of the video for you to follow along with and reference. Just give me a few seconds. Let me pull up the first item on the docket. We should be joined shortly with other contributing members. Let me start by sharing my screen. Okay. All right, push 1 in the chat if you can see my screen. All right. What we want to talk about today is the impact of Black health disparities in the healthcare system. Okay. And we've been talking about this for months, but we had a series that we were running a couple of years ago during the pandemic called Pandemic Talk. And what we were focused on was the impact of COVID-19 on Black people, more specifically Black men. And so we've been covering this type of stuff for the last couple of years and decided to go back into it recently with some discussions. And so what we're going to do is actually break down some of the numbers of the inequity that came out of Blue Cross Blue Shield. They're the only organization in the country that have provided, as an insurance company, healthcare insurance company, these sort of numbers about equity. Okay. And so what we're going to do is actually go through this material. So let me go through this real quick. Let me zoom in. All right, this is from Blue Cross Blue Shield of Massachusetts Health Equity Report. It says at Blue Cross, we have a deep commitment to quality, affordable healthcare, and that includes equity. As part of our commitment each year, we gather and publish data for more than 1.4 million of our commercial Massachusetts members using measures widely leveraged by health plans and clinicians to monitor healthcare quality. See our 2021 data report below. This data has revealed racial and ethnic inequities in many areas of patient care. In partnership with the clinicians in our network, we are using our data to make meaningful change and to work toward our shared goal of eliminating racial disparities in the care of our members, our members receive. Okay. Read covers for examples on how we are partnering with Massachusetts provider organizations to address inequities in healthcare. So let me make this legible. So it says chronic conditions. Okay. We have asthma, we have somebody trying to get in? No. Asthma, comprehensive diabetes care, HbA1c poor control. So low rates indicate higher quality care, comprehensive diabetes care, uh, retinal eye exam, controlling high blood pressure, kidney health evaluation for patients with diabetes, statin therapy for patients with diabetes, and statin therapy for patients with diabetes receive statin. So let me go over this real quick. So it shows for asthma medical ratio 84.30% for Asians and 69.60% for Blacks, 74.20% for Hispanics, and 78% for whites. The percentage of members with persistent asthma who took appropriate medication, ages 5 to 64. Okay, Blacks have the lowest. And so the inequity here is that Black people are not getting appropriate medication for their condition. Okay. Comprehensive diabetes care, blood pressure control. Asians at 78%, Blacks at 71%, and Hispanics at 73%, and whites at 78%. Okay, this is from age 18 to 75. So again, Black people are at the lowest within the demographic breakdown. Shonda, I sent you the link, so make sure you check your email. All right, comprehensive diabetes care, HbA1c pore control. This is interesting. Percentage of adult diabetic members with uncontrolled HbA1c diabetes age 18 to 75. 21% for Asians, 27% for Blacks, 31% for Hispanics, and 24% for whites. Lower rates indicate higher quality care. Lower rates indicate higher quality care. So this is what we're dealing with here. Things should be equal across the board, but it's not. And that's really what Blue Cross is trying to get down to, as to why do you have these disparities? Why do you have Black people at the lower end of the spectrum, despite the fact that, you know, care should be equal across the board? Why are they always at the end of the spectrum? Well, let's read more into this. I'm not going to read all of this, but I'm just going to read some of the more known conditions. Controlling high blood pressure. Percentage of adult hypertensive members who keep their blood pressure controlled, 18 to 85, ages 18 to 85. So 73% for Asians, 65% for whites. Now there's an asterisk next to Asians, Blacks, and Hispanics, and I find that to be interesting. Let me see if I can find a legend for this. I don't see anything listed there, but there's an asterisk next to it. So anyways, 73% for Latinos and 78% for whites. You know, one of the things that we found in some of the research is that based on a person's zip code can determine their life expectancy just by zip code. Let me just scroll down through this real quick. And, actually, I'll drop the link in the chat because I think that some people may want to join this discussion. Hold on one second. All right, let me share my screen again. All right, mental health. Antidepressant medication management acute phase. The percentage of adult members who remain on antidepressant medication for at least 12 weeks, ages 18 plus. Asians at 69%, Blacks at 59%, Hispanics at 63%, and whites at 77%. So what we see here, the disparity here is that Black people are less likely to maintain their medication for antidepressants. Makes you wonder about the manosphere with a lot of the content creators and some of the folks in the chat room, how antidepressants may be impacting them. Antidepressant medication management continuation phase. Percentage of adult members who remain on antidepressant medication for at least 6 months, ages 18 plus. So 53% for Asians, 42% for Blacks, and 44% for Hispanics, and 62% for whites. So again, Black people are at the lower end of the totem pole on this. Follow-up after emergency department visit for alcohol and other drug dependence, 30 days. So there's not enough sufficient data to even calculate this because I guess they weren't tracking this. But they did have it for whites and Hispanics, and you can see that Hispanics are significantly lower than whites, all right? Not enough sufficient data to cover the rest of the conditions. Appropriate treatment for upper respiratory infection. The percentage of upper respiratory infections that did not involve an antibiotic prescription, ages 3 months or older. 98% for Asians, 95% for Blacks, and 95% for Hispanics, 94% for whites. Now, here's what I suspect. Because childcare is so frequent for, in pediatrics, you're more likely to be seen than you're not. And so you can't really discriminate against a child coming in to see their pediatrician. So I think when you start talking about that, I think you start to see disparities as they get older rather than as they're at birth up until about 5 years old. So, they're always going to, you have children's hospital systems and other pediatric clinics and things like that. So they're obviously going to have more access to quality care than they're not. At least that should be the case here. Use of imaging studies for low back pain. Our percentage of adult members diagnosed with low back pain who avoided unnecessary x-rays, CT scans, or MRIs, ages 18 to 50. Asians at 82%, Blacks at 81%, Hispanics at 80%, and whites at 81%. So we do know that having access to that kind of medical infrastructure makes a lot of sense. And so you're not seeing that much of a disparity between the two other than a percentage point or more. So all right, prevention. Child and adolescent. Well, it seems like 2 people trying to join. All right. Sorry, just got sidetracked, people joining. When it comes to prevention, child and adolescent well-care visits. Percentage of child and adolescent members who had at least one comprehensive well-care visit with a PCP or OBGYN, ages 3 to 21. Asians at 82%, Blacks at 70%, Hispanics at 70%, and whites at 81%. So why do whites and Asians have similar outcomes, but Blacks and Hispanics have similar outcomes at the lower end? See, this sort of data is important to actually create public policy and push initiatives. You shouldn't have this, but what I do know is that Asians and whites tend to work and live amongst their within the same environments. Blacks and Hispanics tend to work and live within the same environments. I think beyond that, I think that portion becomes relevant as to what kind of outcomes they're going to get from all of this. It shouldn't be different, but that's what they're reporting. This is interesting. I hadn't read this in a while, so I'm kind of taken aback by this. What's going on, Shonda?
Good evening. How are you?
Good evening, yourself?
I'm doing well. Good evening, everybody.
All right.
Good evening.
All right, let me just finish covering this real quick. Cancer screening. Now, this is interesting. Percentage of adult members who had appropriate screening for colorectal cancer, ages 50 to 75. Asians at 60%, Blacks at 58%, Hispanics at 60%, and whites at 68%. Why is the number for whites so significantly higher than everyone else? I don't know. Especially Black people at that age, 50 to 75. I suspect that you have a lot of Black men who wait to the very last minute, or they just don't have any healthcare coverage beyond 50. That could be a possible guess. I think that Black women tend to see their doctors more frequently because, you know, they have a lot more going on with them. And so I think the relationship may be a lot more intimate than, you know, than it may be for Black men. And that could be why you see such disparities for Black versus white. Shauna, do you have anything that you want to add in on it?
I would agree on that. One of the things I see is that a lot of times the access to care is limited for various reasons. And then also, if the individual doesn't have access to care, then you can't do those preventative health screenings in time. There's also a lot of distrust within the greater medical community amongst African Americans, particularly African Americans in the South, as well as throughout the United States. And there's much historical context for that. But I think that's one of the reasons why you see a lot of this not either being done or done in a timely manner.
Mr. Cool, you have anything you want to add to this?
Yeah, this is Matt Bone here. I've learned over the years, studying from the works of Dr. Layla Africa and Dr. Carrie Barnes, that the reason there have been problems concerning Black American men is due to our unique cultural and mental physiology. There's certain medicines that are not chemically or molecularly aligned with our unique melanin genetics, especially concerning the pink pineal and pituitary glands. So when we up there try to attain optimal health in line with other cultural standards such as Asian and Caucasian, that is a holistic disconnect right there. And, you know, we look at the history of what happened with Henrietta Lacks and also the Tuskegee experiment. So we have always had a long distrust of the American medical institutions and infrastructure. Like over the decades, Henrietta Lacks families have been trying to develop court cases to sue to get their elders' remains back. And, you know, that's the thing. I noticed that, and from my own experience in this COVID pandemic, I learned that use some certain organic and natural substances that made me immune to the effects of the COVID and the vaccines. So, like I told others, I even, gave younger folks remedies on how to deal with it. Take chlorella, vitamin D3, and black elderberry. Because when it first hit back in 2019, I was surprised that a lot of these low vibrational thinking Negroes were more concerned about trying to get a whole bunch of chicken and toilet paper than getting black elderberry. Very super food that will like keep them immune from COVID. And then also, due to our unique molecular melanated genetic structure, the sunlight helps make melanated Americans immune to COVID, because the COVID virus cannot survive in the area of heat.
Yeah. Let me finish reading. Let me finish going down this this report.
Go ahead.
Yeah. All right. For women's health, breast cancer screening, the percentage of women who had at least one mammogram within the past 2 years, ages 50 to 74, Asians at 74.5%, Blacks at 74.9%, and Hispanics at 78%, whites at 79%. That's interesting. When it comes to women's health, you start to see very close similarities, regardless of the demographic makeup. Sean, do you have any idea why that would be?
One of the reasons is lack of access to care. Then two, a lot of the healthcare providers don't know or don't try to understand that there's certain breast conditions that are more prominent in African-American women, and they typically present at a younger age. So like for breast cancer screening, unless a woman is under the age of 40 and she has a strong family history of either a first degree or a second degree relative like mom, grandmom, aunt, or sister that has breast cancer, they're not going to order a mammogram on her before age 30. But what the medical evidence does support, and has supported this for decades, is that in Black women, XXX breast cancer is more so diagnosed, and it's usually diagnosed prior to the age of 40. If you see a woman that's in her late 20s, in her early to mid 30s, she's not obese, she doesn't smoke, she doesn't engage in a lot of high risk health behaviors, but she's diagnosed with breast cancer, particularly if she's a Black female, that's usually XXX, and that's a more aggressive breast cancer. So by the time that they've found it, it's usually either stage 2, 3, or beyond, or it could have metastasized to other areas. So I think that's one of the reasons why we see the higher numbers. Or you may see Black women getting diagnosed at similar rates of white women, but as far as mortality from breast cancer, Black women have a higher incidence of that. Similar with Black men and prostate cancer, and we can elaborate on that later on.
Okay. Cervical cancer screening. Oh, we already went over that. Chlamydia screening for women. What? Percentage of women who were appropriately tested for chlamydia? Ages 16 to 24, 73% Asian, 77% Black, 71% Hispanic, and 69% white. Wait a second here. Why are Black women seeing such high rates?
That question's for me, Mike?
It's where anybody can answer that.
So I can speak to this one because I work in primary care. So I see this on a weekly basis. For standard screening, the guidelines do not recommend a pap smear, which is the test that we do in females to screen to see if there's any concerns for HPV. It's 16 to 18 different strands of that, or human papillomavirus. As well as it tests to see if there's any early presence of abnormal cervical cells that can put the woman at risk for uterine cancer if it's untreated as she continues to get older. But the recommendations are, unless a female is not sexually active, and we know nowadays most females are sexually active way prior to the age of 2021, a PAP is not indicated. Unless, this is the caveat, she has engaged in sexual activity with multiple sex partners, whether that be male, female, or both, or there's a strong family history of cervical, uterine, or some form of cancer at a younger age. So one of the reasons why you see the high incidence of that is, one, the testing is not being done in middle school, in high school. Two, I'm not a parent, but I think some parents may feel some type of way with their 12 or 13 or 15-year-old daughter or son telling them, hey, I need to go to the clinic to get tested because I had a burn down there. It needs to be addressed, but there's a sense of ambivalence during that age group to where, they may feel invincible, or they may not, think it's something that they need to get checked out, or, oh, it's just going to go away, this is that or whatever. And that's one of the reasons why it's not being screened properly.
Is that because of laws, or is that just because of, I don't get it.
It depends on the state. So,
okay.
In most states, if you're under the age of 16, even though in a lot of states, 16 is the age of consent, but in most states, if you're under the age of 17, you have to have a parent or a parental guardian or someone who is, legally licensed or legally designated guardianship over you, unless you are an emancipated teenager or individual. They have to sign off on your healthcare services. So you may seek that, or you have some individuals lie about their age and it's not verified. But if the parent does not consent to that child being screened or tested or evaluated, it doesn't have to be done, even if that young man or young lady knows, hey, something is not right down there. So I think that's one of the limitations. The schools don't have the authority to make that decision unless there's just like a rampant outbreak of that, either in the school or in the area. So a lot of times you see it very much go underdiagnosed, or it's not treated at all.
Okay, that makes sense. That makes sense. I would think that they would want to collect this data as early as middle school. If these kids are having, kids in middle school, that would be the optimal thing to do. Non-recommended cervical cancer screening in adolescent females. Lower rates indicate higher quality. Asians at 0.10%. Blacks at 0%. Hispanics at 0.44%. And whites at 0.30%. I don't know. Mr. Cool, you have something you want to add?
Well, the thing about my experience, what I learned, like when I started to turn, when I turned 40 back in 2019, that's when I started getting like prostate, cancer screenings. And I realized that usually a lot of Black American men would usually die from either hypertension, stress, or like diabetes and prostate cancer. And what I discovered in my experience, I dealt with a doctor, but also learned from, soul, spirit, and nature on how to get better with that. Like one of the recommended nutrients that keep men from developing prostate cancer is like taking that ZMA mix, zinc, magnesium, and arginine. And then there's pumpkin seeds, which keeps your testosterone up. Because due to low testosterone, that encourages the development of prostate cancer as well. And there's certain herbs that protect the prostate as well also, like Damiana and Yohimbe, that sort of thing, and sarsaparilla. And like I had a discussion with my sister the other day. I know that you trust in that white doctor, but that white doctor doesn't have the same genetic and molecular structure as you do. Black American men and women's physiological structure is the most unique on the planet, even different from the Africans over there. So like, I had to look at certain other avenues, because I remember a long time ago, I took a medical astrology exam from Dr. Layla Africa, peace and blessings be upon him, rest in power, back in 2008. I remember when I first met Dr. Africa in Arkansas in February 1996. He told me about being circumspect about dealing with like Caucasian health standards.
Let me finish going down this report.
Go ahead.
Real quick. All right, so MHQP patient engagement survey adults. Getting quality care from staff in the doctor's office. The MHQP patient experience survey is a statewide survey of commercially insured patients in Massachusetts. More information about the MHQP survey. So Asians at 91%, Blacks at 95%, Hispanics at 92%, whites at 94%. I don't have that survey in front of me, so I don't really know what they actually covered, but you know, that's
you're talking about a patient, you're talking about inpatient visit, clinical interaction, right?
That's just what the chart says here. There's a report that goes deep. There's a survey that goes deeper into it. I just don't have it in front of me right now because I'm just going through the numbers as it's presented on screen.
Oh, okay.
Yep. Getting timely appointments, care and information. MHQ patient experience survey is a statewide survey of commercially insured patients. So timely appointments, care and information, 73% for Asians, 80% for Black, and 79% for Hispanic, 83% for whites. This is interesting.
Yeah, I can tell you from my experience, you know, I've dealt with like well care, and due to that, I'm being able to like have certain benefits like medical transportation, but then there are times there's a bad habit of the medical transportation service to certain avenues like Blue Cross and WellCare giving like poor transportation services to Black Americans and everything. So there are times I have to like take another avenue and have WellCare recommend me an Uber and Lyft to get there faster and on a timely manner. And you know, there's a cultural aspect to this. You know, I'm beginning to notice that there are some Hispanic and Caucasian professionals, you know, that having a more you know, interconnected way of connecting with Black patients. And that's why I think young Black American men and women should also deal with like the STEM in the medical fields, like, you know, neurosurgery, psychotherapy, psychiatry, and so on. So there'll be a more cohesive cultural connection. I mean, I think Almond Rob at my PCP primary care physician is a Black American man. I am very thankful for that.
Yeah, let me finish reading these numbers here.
Go ahead. Yes.
How well doctors communicate with patients. Asians at 95%, Blacks at 94%, Hispanics at 95%, and whites at 96%. Okay. This is just for Massachusetts, not around the country. So this is one state, but it's the only insurance provider that's providing these numbers. So keep that in mind.
Mike, can I say something?
You're talking about Blue Cross, right?
Yeah.
Oh, go ahead, sister. Okay.
Mike, when you get finished with that part, may I address something on that?
Yeah, go right ahead.
So with this is it's similar to the surveys that they sent out to individuals who've been hospitalized for any period of time. As a healthcare provider, I question those numbers, even more so when it breaks it down by ethnicity. And one of the reasons why I question those numbers is the data is there in percentage wise, but there's no way to really fully determine at this time, state by state, or even at the national level, how those numbers are substantiated. And what I mean by that is this. Typically, when surveys go out, the individuals that fill them out and return them back usually are filling them out if they're either extremely dissatisfied with the service or they're very satisfied with the service. You do not get a lot of feedback from individuals who either encounter a customer service, healthcare system that have had a decent experience. So whenever I see these, I look at the data, I look at the numbers, but I question the true validity of them, because to me, there's always going to be a high level of I can't even think of the right word, of non-validity to them, because it doesn't ask you when this is going in, okay, you know, what was your actual experience like with this person? If you feel this way, why do you feel this way? And us as healthcare providers get these back, and it's like, okay, you're not providing this for the patient, you're not providing that for the patient, you're not providing this for the patient. Well, if this patient has only encountered me once, but they're determining whether I have a 5-star rating on, you know, Google Doc or this is that or whatever, I don't think that's an adequate assessment versus someone who has been my patient for 2-3 years, and the survey goes out every quarter and they never fill it out. So I think it's a good tool to start at, but I don't want these numbers just to be, you know, this is the law, this is what it is. I know that's not what we're saying, but I just want to put that out there, because a lot of times that's what happens, but it's not a true reflection of what's really going on.
Right. And it's the only.
Hey, Shonda, I got a question to ask you. Do you have access to like the WellCare stats concerning it?
I do not have direct access with it, but I'm very familiar with it. And they're making a lot of updates in the system within WellCare right now. Government is a lot of redundancy. But I could likely get it, but I do not have access to that right now.
Okay, because I've been dealing with WellCare myself ever since 2013, and I've had some, pretty good benefits, transportation service. They've also provided me like free gym memberships to LA Fitness and Planet Fitness, stuff like that. And also like, I get a visit from the nurse, in-house visits, that sort of thing. So they've been helping me keep in touch with my appointments, and that sort of thing.
Yeah.
I mean, I try to do my best to take a just holistic approach to what's going on, because we just can't put all our health dependence on the system.
Mm-hmm.
That's some stuff we have to do for ourselves.
Mm-hmm. Let me finish going down this chart, that we can move on to the next item on the docket. All right.
Okay.
How well doctors know their patients? 88% for Asians, 89% for Blacks, 90% for Hispanics, 91% for whites. These are just numbers from the survey. Take it with a grain of salt, but that's what they provided. So, all right. The link is in the chat. Not in the chat, in the document description, need the video for you to reference if you want to look at that stuff on your own time. I think that it's in everybody's interest to know what's going on. So let me share my screen again. Oh, we already covered this, so I won't go back into this again. This has already been covered. So let me jump to this next item. All right, let me share my screen. All right, this is one from the Boston Herald. Health disparities among communities of color cost Massachusetts $5.9 billion a year. New report from Blue Cross Blue Shield focuses on consequences of health inequities. Zoom in on this. Health disparities experienced by communities of color cost Massachusetts about $5.9 billion a year, with a quarter of the economic burden associated with avoidable healthcare spending and another quarter due to lost labor productivity, according to a report released this morning. Supporters of the new study commissioned by the Blue Cross Blue Shield of Massachusetts Foundation say it helps reveal the broader consequences of health inequities and what the fuck is this? That was all right, just bear with me for a second. This website just froze up on me. All right, let me get back to this. Supporters of the new study commissioned by the Blue Cross Blue Shield of Massachusetts Foundation say it helps reveal the broader consequences of health inequities and provides motivation for public and private sector leaders to help rectify the disparities. The research also looks to the future of the state's population, where communities of color driving growth, but are also the ones who are the most heavily impacted by health inequities. As the next generation rises, the report said these groups will represent nearly half of the state's population compared to less than 1/3 share they represent today. Quote, Massachusetts faces a choice to pay now or pay greater later, as demonstrated by this report, which highlights the unacceptable costs paid by communities of color and ultimately borne by businesses in the Commonwealth. The advocacy organization Health Equity Compact said in a statement included with the report. The authors of the report said it is first of its kind to quantify in economic terms the cost of health inequities for individuals and families, healthcare providers, employers, public and private sector payers, and the overall Massachusetts economy. The economic burden associated with health inequities experienced by communities of color in Massachusetts totals nearly $6 billion, but could grow to $11.2 billion by 2050 if no action is taken. The time to shift from awareness of the problem to action on solutions is now after analysis made clear the staggering economic toll of healthcare disparities, said Audrey Shelton, our president and CEO of Blue Cross Blue Shield of Massachusetts Foundation. Our Commonwealth led the way in expanding health insurance coverage and improving access, and we have a shared responsibility to act similarly to achieve health equity and eliminate health disparities, Shelton said in the statement. Populations of color in the state are disproportionately affected by housing instability, food insecurity, environmental toxins and stressors, and higher rates of poverty as a result of longstanding systemic racism in social and economic structures, policies, and practices, the report said. Whoops, let me go back. That has led to less access to health coverage and care, and differences in the quality of care received, researchers wrote in the study. Differences in delivery of care also stem back to, quote, mistrust in the healthcare system due to historical and systemic racism and experiences of continued lack of respect and breaches of trust, reported by many, the report said. Researchers found his Black and Hispanic Latino residents report poorer health and mental health statuses than white residents. Pregnancy-associated mortality and severe maternal morbidity are higher for Black residents, and higher rates of diabetes and asthma are reported among Black and Hispanic Latino residents. Higher rates of disease and disability in a population require more healthcare services to treat those conditions, which means higher healthcare spending, researchers said. Quote, by computing the gap between healthcare spending under the current current health status for Massachusetts adults and healthcare spending, if populations of color achieve the health equity target health status, we estimated that avoidable healthcare spending due to health inequities is $1.5 billion each year, or about 2% of total Massachusetts annual health spending, the report said. Working age adults are less healthy. Working age adults who are less healthy tend to work fewer hours, take more sick days, and be less productive on the job, the report said. The analysis compared the productivity of working age populations of color with their current health status to the same group if they were fully healthy. We estimated that health inequities experienced by populations of color today cost Massachusetts $1.4 billion each year in lost labor productivity across industries, the report said. The analysis also compared the current mortality rates by race and ethnicity at each with the health equity targets for mortality at each age. We found that health inequities are estimated to lead to premature death of Massachusetts residents of all ages, the report said. Here's my take on this as somebody who lives here. I do see a lot of people a lot of Black folks taking days off, especially women, either because they have cramps or they have other pre-existing conditions or things that can't be spoken to, but they do tend to take a lot of days off. I'm actually a personal trainer outside of YouTube, and one of the things that I have found is that women tend to blow off appointments when it comes to personal training than men do. Men are more likely to go out there and try to get it in, but what I have found is that women tend to blow off a lot of days in the community. They may come to the gym maybe one time a week, whereas you may see men in there more 2 to 3 times in a week. And so I think there's a variety of things in the environment that play a significant role in this. I do think that environmental pollution plays a significant role. Climate change plays a significant role in a lot of these disparities that you see. Asthma is one, and especially in the summertime, you can tell the difference between the environment. I was just out today before doing this stream. I went to outside of Boston, which is the Watertown, Lexington area, and you can smell the air quality is dramatically different. The air quality is just different. Everything's cleaner. And when you come back into predominantly Black neighborhoods, you definitely smell a lot of pollution. It's just really hard it's hard to breathe. If I could describe it that way. And so what you're seeing here are people who are just trapped by the environment. If I can say that, it's just a lot of issues that need to be solved. I don't know if they're willing to solve it. And Massachusetts is not necessarily, or I shouldn't say Boston is not necessarily that bad of a place to live. It's just that it costs a lot to live, and the environment tends to play a significant role on people's health, depending on what zip code they live in, if that makes any sense. Shonda, you got anything you want to add on this?
It makes total sense. And that slide that we may have time to go over later, where it outlines the health disparities and health equity state by state. Massachusetts has one of the better healthcare systems in the country, not only just for all of its citizens, but for African Americans or for those of melanated descent compared to other areas. So if it's 5.9 billion in your state, what is it in like a place like Mississippi or Alabama, Georgia, Louisiana, Texas? So this is definitely something that needs to be addressed. One thing I do know is there's not enough funding in preventative care. A lot of the conditions that we see on these statistics, that we hear about, that we read about, that we even know within our own individual families or individual groups, a lot of these conditions are preventable. But there are multiple reasons why, we're disproportionately affected is lack of access to care. Food deserts are very much, live and well in America throughout the East Coast, throughout the American South, even in mid-America, and that disproportionately affects people that look like us. You also have the structural racism aspect, financial aspect. It's so many layers to that. And then also the historical distrust of the medical community, because a lot of the individuals that are providing these services don't look like us. So it's a cascade of dynamics that play into this. Can it improve? Absolutely. Do we want to fix it? That's the question that we all have to ask ourselves, and how are we going to go about collectively trying to do that?
Mr. Cool, you have anything you want to add to this before we move on?
Yes, I'm here as a resident in Dallas, Texas, and I noticed that there's been a increase of homeless people, especially in the downtown Dallas metropolitan area, due to a lack of mental health care and also preventive health care. I remember I made a trip with a friend of mine down to one of the food banks down there, City Square in downtown Dallas. And they are beginning to serve healthier food to the homeless people. And the people have like a lot of low lack of funds to get food. So it is improving a little bit. Yet I found that there's been some mental health and preventive healthcare centers that have like a lack of insurance connections to people of melanated hue. Like they don't have insurance covering like the hepatitis A and B vaccine. You have to like pay like about $120, $150 at least to get that. But like back in the past, you was able to get like the hepatitis A and B bottle shot even at your regular PCP doctor, or at like places like Walgreens and CVS, covered by insurance, or even the hospital. Now they don't have it like that. You gotta go to like neighborhood, clinics.
Mm-hmm.
So
they don't do insurance. You have to pay the money up front for that.
So I hate to interrupt, Mr. Cooler.
Yes, go ahead.
Go ahead and finish your statement, but
I mean, a lot of
that is not
there's
information that's being
okay. Because there's some stuff that's changed for the better over the decades, but then there's some stuff that still needs, improvement. And our people need to have like a collective, self-awareness, self-control, and self-reflection concerning health and everything. When we talk about the medical systems run by people and not us, they're run by people who have a totally different molecular and genetic structure from us.
So I and Mike, you're overseeing the panel, so I'm not trying to interrupt. I'll wait, but you have to be very mindful about context and information going out, because it's not only people that are listening to this now, but people are sharing this stream. It's likely going to be up for people to assess this in the future. So we have to be very careful about what is being said and make sure it's as accurate as possible. Respectfully, Mr. Cole, I understand where you come from. I understand.
Yes.
But some of that information cannot be substantiated. And as a healthcare provider, I can't let that go out and not rebut.
Well, I understand.
We as African-Americans are uniquely created, but to say that other people don't have a molecular makeup similar to us is a fallacy. You know, we are part of the African diaspora, so we are linked to the original men and women. Now, they are descendants of that. They don't want to accept that. And some of the pharmaceuticals that are used don't benefit Blacks like they do others. And there's multiple reasons for that, because we've been left out of the trials or we don't volunteer for the trials. But as far as like access to certain preventative vaccines, though that's accessible through Walmart, through CVS, through other agencies. So I think we have to be mindful. I'm not saying that there's not room.
Well, ma'am, I have been mindful. That's what I learned from my experiences in real time, life in real time. Because I took a niece of mine over there to try to get the hepatitis A and B vaccine. They referred us to a clinic in Garland, Texas. And then the insurance, didn't cover that for the hepatitis A and B vaccine. So I had to pay money in my pocket. This is what I learned from real life experience in real time. And due to what my elders have taught me about what was going on culturally for these past few decades, ever since the early 20th century, what we went through concerning this, due to the behaviors that other people have treated toward us, especially the Melcombe community run by the Caucasians, it is what it is. Whether people think it's a fallacy or not. This is what I learned from the cultural experience concerning my families, both African and Native American. So we need to learn how to think outside the box here, and not just depend on statistics that we get from the power structure. We have to learn from within ourselves, and whether our elders taught us, whether the African and Native American.
Yeah, let me finish going through this next item on the docket. All right, this is from kff.org. Shonda provided this. Thank you, Shonda. How recognizing health disparities for Black people is important for change. February 1st marked the beginning of Black History Month. The 2023 theme for Black History Month is Black Resistance, an exploration of how African Americans have nurtured and protected Black lives and fought against historic and current racial inequality. In fact, while Black people have made great contributions and achievements in the United States, they continue to face many health and healthcare disparities that adversely impact their overall health and well-being. These disparities have been exacerbated by the uneven impacts of the COVID pandemic, ongoing racism and discrimination, and police violence against and killings of Black peoples. Moreover, the long history of inequitable health outcomes among Black people reflects the abuses faced during slavery, segregation, and mass incarceration in their persistent legacies. Black people make up 12% of the population in the United States as of 2021. The Black population this is a typo or something. The Black population has grown by nearly 30% since 2000, with the increase in foreign-born Black people playing a significant role in this growth. As the population has grown, it has become more diverse, with an increase in the share of Black people who identify as multiracial or Hispanic. So this is a chart showing up the population. It's a pie chart showing the population.
The thing about it might be when they talk about the disparities, these people have outlined this. Dr. George DeGrue, Dr. Layla Africa, Dr. Jewel Pulcrum, and Dr. Julia Hare have outlined this. Now, Dr. Layla Africa, peace and rest be upon him, has had experience in the medical field and also in the holistic orthomolecular field. And he also learned holistic disciplines from African elders in West Africa. So he learned from the mainstream power system and the elders. So we just can't look at just depending on statistics from the system. We got to look within ourselves and within our own cultural dynamic to come up with solutions about this. We got to look at the whole gist of the experience, not just one iota of that.
Yeah, let me finish reading this whole thing though.
Go ahead, sir. Yeah,
Before we start commenting on it. Yeah, Black people
Yes.
face increased barriers to accessing and utilizing healthcare. Black people are more likely to report financial barriers to receiving healthcare, while the implementation of the Affordable Care Act and pandemic era policies have helped narrow some disparities in health coverage. Non-elderly Black people, 11%, continue to have a higher uninsured rate than their white peers at 77%, figure 3. Further, compared to white people, Black people are more likely to face social and economic challenges that adversely impact health, including higher rates of poverty and food insecurity. Black adults are also more likely than white adults and to report being treated unfairly because of their race, ethnicity, while seeking care for themselves or family members. This is the percentage of non-elderly adults who did not see a doctor due to costs in the past. Let me just say this real quick about this. In this country, healthcare should be as easy as ordering, from Domino's Pizza. Okay, you should be able to pull up an app on your phone for your local provider, and you should be able to book an appointment, or you should be able to seek telehealth. I think that AI is going to play a significant role in that, but I also think that we make it inaccessible. There's enrollment periods, there's which contributes to why so many people are uninsured. They fall off the radar, and they go months and months without coverage, and then they get into a situation they can't get themselves out of, and then they got to use the emergency room as a primary care visit, and then it costs the state more. It costs $1,900 now for an ambulance ride, and they get billed with that. It's unbelievable how fragmented and congested the system is. It's so it's not cohesive at all. It's something that needs to be solved at some point, or like the previous article said, you're going to pay for it later. Uninsured rates for non-elderly population by race, ethnicity, 2010 to 2021. We see the American Community Survey did not release the one-year estimates for 2020 due to significant disruptions to data collection brought on by the coronavirus pandemic. Black people are more likely than white people to face social and economic inequities that negatively impact health. This is true. Okay. Percentage of adults who report being treated unfairly because of race, ethnicity while getting healthcare in the past 12 months. You hear it all the time. I think Mr. Cool has elaborated on this. Reflecting these inequities, Black people report having worse health outcomes compared to white people. At birth, Black people have shorter life expectancies compared to white people, and they experience a larger decline in life expectancy than white people between 2019 and 2021, with it falling by 4 years. Black people have the highest rates of infant mortality and maternal mortality across all racial and ethnic groups for which data were available, and experienced the largest increase in maternal mortality when compared to pre-pandemic levels. Although Black people fare better than white people for some cancer screening and cancer incidence measures, they have higher rates of cancer mortality. The underlying inequities in health and healthcare for Black people also contributed to disparities in COVID-19, with Black people facing a higher risk of hospitalization and death due to COVID-19 compared with white people. Moreover, the disparate effects of COVID-19 may lead to widening disparities in health going forward. Yeah, this is true. We've covered this on our pandemic series with Dr. Phoenix, and also Supertriz. And what we have found is that all of the inequality that existed pre-pandemic came out during the pandemic. And I know here in Boston, what folks on the ground did is they they created their own task force for addressing, vaccine inequality. And so they were the first ones to go out and start surveying the neighborhoods and canvassing the neighborhoods and collecting data on who's impacted and who needs vaccines. And so they were able to get vaccines out to people a heck of a lot quicker using basketball gyms and other gym forms of boys and girls clubs and things like that to address these sort of issues. And so we've talked about this in the past. I think that you would think that the 14th Amendment would be utilized to actually try to address some of these issues, but there are so many people who are against things like affirmative action and DEI and things of that nature. They'll watch you, they'll watch you suffer before they actually address some of these issues.
And
that's the thing about the 14th Amendment. The 14th Amendment, it transferred the jurisdiction of, slavery from the private owners to the prison industrial complex, government corporate. That's what the 14th Amendment did. Like when the Black American men and women get locked up, they become a part of that through private prisons, which help, upscale corporate interests. And there's a political side to that as well. That increases the further inequality of that. And like I told my people, you gotta, there needs to be not only a psychological re-education of our people, there needs to be a political re-education of our people as well.
Shonda, you want to?
The other thing too is one of the slides that you highlighted. I think it was before this one. You don't have to go back to it. Is you all have addressed this, and other platforms have addressed this too. Being in the healthcare system, it was a lot of strain on the system before COVID, and even more strain on the system now, because you've had countless physicians, nurses, other specialty providers that have left or are actively planning to exit healthcare since the pandemic. Now, COVID is not as prominent as it had been the last 3 years, but it did blow the lid off of things. There's no perfect system in place. There's always room for improvement. But the other thing that stuck out to me, and I think this came out last year, was as far as life expectancy amongst groups. Other individuals' life expectancy numbers have increased, but there's been a 3-year decrease for life expectancy amongst Black men. And that came out, I believe, in 2021 or early 2022. Why is that? That wasn't just because of COVID. It's no reason why, and this is where health disparities and what the subject of today's conversation is based around. It's no reason why an individual in the United States or anywhere in the world, but we're focusing on the US now, shouldn't be able to go and get a preventative health exam, whether they have insurance or they're uninsured or are not. And it's multiple roadblocks that prevent that from happening or prevent that from happening on a consistent basis. I can't tell you the number of times I see someone that, maybe in their early 30s, in their late 40s, and when they come to just get a routine, exam because they may have a cough, the blood pressure is off the charts. We do blood work on them and they're in advanced kidney disease. That doesn't mean that your blood pressure was elevated just that day. This has been going on for years. This is where access to care and health disparities all ties in. We can talk about this all day long. It's a great conversation to have, but what are we going to do about it? And herbs and vitamins are great, but holistic health is important. I'm not picking one side between the other. They can both work conjunctively together. But we need to get more serious and more active about how we can fix this problem. The healthcare system is overwhelmingly, Anglo-Saxon, as well as more Indians are coming into it. But we need to also look at how can we improve that amongst people that looks like us. And I think that those numbers can increase, but we have to want to do it.
Absolutely.
I mean,
absolutely,
one part
absolutely.
that starts with the resurrection of the traditional nuclear Black family. That's where it starts. And also dealing with like some local community centers that will help pick up the slack, be a part of some of those council meetings, those commissioner meetings, especially when it comes to mental health and physiological health. And like ever since that COVID thing happened, oh, go ahead. Yeah. Okay.
Yeah, let me read the question from the chat from Nameless Protagonist. He says, can the panel speak anything on potential healthcare subsidy that people may not be aware of? Because there is definitely a stigma against those perceived to have healthcare and not. Sean, do you want to chime in on it?
So from my understanding of that subsidy is, I believe it's for individuals that make under $50,000 a year. I don't have all of the data in front of me, but from my understanding, that's how it works. Now, the question is that $50,000 an individual, or is that $50,000 per household? Because if there's more than one person in the household, then that need increases because everybody's going to have access to care. I think they're doing it kind of similar to what they did with the COVID stimulus a couple of years back. And if you made over a certain amount, you didn't get that. What I can say, and hopefully this ties into the Nameless Protagonist question, is a lot of times individuals get a false sense of security with insurance. And what I mean by that is this. If you have healthcare benefits, whether you pay for it out of pocket, if you signed up through the Affordable Care Act, through the marketplace, or if you get health benefits through your employer, depending on what your healthcare needs are, what your family healthcare needs are, what your annual or monthly income is, then you may be underinsured, which means on paper you have insurance, but to adequately meet the needs of what that insurance covered, that may not be enough. And I see that over and over and over again. Individuals who have private healthcare insurance, or they may have well care or a well med. One of the big things that's going on since June, I think, is when the individuals that were granted the temporary Medicaid during the pandemic, the government has pulled all of that. And you've had millions of people that have lost access to care, or they can't afford to get care now. Just like here in the state of Texas, we have one of the highest uninsurance rates in the country. As many people live here, as many resources as Texas has, is no reason with the population of 36 million plus that you have that many people that do not have access to quality care. What does that translate to? That translates to when people go to, have a headache, they're going to go to an emergency room versus going to an urgent care center, or going to a primary care office, or they're going to, have a gamut of tests to where we can do something that costs $50, $75 versus charging them for a $5,000, $7,000 CT or MRI. This is where health disparities and access all ties in. So even like with Medicaid, they're limiting that. And particularly in the states like here, in the other 9 states, Kansas, I think Georgia didn't take the Medicaid expansion. Now all that's coming to bite individuals back in the foot, because if you have insurance, you should be able to go see a specialist if you need to see a specialist. If you need mental health services, that's a big area in the healthcare system that's not properly serviced, or you don't have enough providers, or you definitely don't have enough providers that look like, us on the panel or us in the chat. Well, in the state of Texas, if you have Medicaid, good luck finding a psychiatrist or a psychologist, because most of them don't take it. That's a problem. So those are the things that, with those slides that I sent you, Mike, and what we're talking about, we have to be knowledgeable of, because it doesn't get people to where they need to, or you can get them set up on something and they may not be able to maintain that level of care that they need. And it disproportionately affects Black and brown people.
Now in Georgia, Sean, there's several clinics or hospitals actually being closed, major hospitals being closed down here. I don't see how Black people are going to get access to, the necessary services if you shut down a major hospital that is within their zip code. I think that's it's one of the things that's going to impact people even further. If it takes you 20, 30 minutes. Yeah, if it takes you 20, 30 minutes to get to a hospital, that's the difference between life and death for you.
Absolutely. Yeah. And it's all being done by design, because a hospital or a clinic just doesn't randomly close, overnight. Like, this is stuff that's been plotted and calculated and planned in private meetings, some in public meetings, way before it's acted out. But that's where it goes into us being, knowledgeable politically. And I'm not saying that we have to know everything from, the Constitution to the Bill of Rights to our state constitutions, but it's information that's readily accessible in this day and age that we have access to and can gain access to where we can counteract this before it's officially rolled out. They're closing those hospitals in places, like Georgia, in the inner city of Atlanta, or, the rural areas, to where you may have to drive 50, 80 some miles to encounter an ER or a hospital. Where if you're having an active heart attack or a stroke, you don't have that time, kind of time. They're not doing it in the white communities. They're not doing it in these gated communities. It's disproportionately affecting the inner city individuals, as well as those that are in these outlying rural areas. And the question I ask is, why is that? It's done by design, but it's too many of us sleep at the wheel.
And see, that's the thing about it. There's always a current connection connected to the political, corporate, and prison industrial complex sector. Like in the prison industrial complex sector, there are certain prisons, they're improving their health care for inmates. And they've been starting that since 2020. And then, that's the thing, like, there's ways you can go about it, look up some apps to help you get better care. You can look online. There's been a increasing number of some friends of mine trying to get into well care too. Because like Shonda, you said, there's according to your income level and also to your family structural level as well, whether you have a full household or whether you're single. Yeah. And then when you go from that template, you can find out, researching online and researching among your offline connections, what sort of suitable healthcare is able to be connected to your individual needs and to your family's needs by doing the proper research and legwork.
One of the things I wanted to actually highlight as well is that you have several Black men in the management who have passed away in the last couple of years. Okay, and you see this a lot more. And you see the conditions of that they had that led to it as being reflective of the healthcare disparities that Black people face and that they're impacted by. But nobody in the management wants to have that conversation. Let me finish reading this.
David Carroll, Roger Curry, and Kevin Sanders.
Yeah, I mean the names don't matter. You can run down a list of names. There's a lot of Black men who have passed. Yeah, let me just finish reading this. Yep.
Yes.
Ongoing racism and discrimination, police violence against and killings of Black people, and gun violence also negatively impact health and well-being of Black people. Black people's repeated and chronic exposure to stressors associated with racism and discrimination drive rapid biological aging and poor health outcomes. Black people are more than 3 times as likely to be killed by police than white people. And over the course of a lifetime, 1 in every 1,000 Black men can expect to be killed by the police. This exposure to police violence has been found to have negative mental health outcomes for Black people. Black youth have also been disproportionately affected by gun violence, which can adversely affect the mental health and well-being of children. Data show that firearm death rates sharply increased among Black youth during the pandemic, largely due to gun assaults and suicides by firearm, which overall rates of mental illness and substance use disorder are lower for Black people compared to white people. They may be underdiagnosed among people of color. Data also point to increase in mental health needs as Black people have experienced a faster rise in deaths by suicide and drug overdose deaths compared to white people. These findings highlight the most important highlight the importance of addressing mental health needs among the Black population and reducing barriers to treatment. One of the things that I found in my travels through Africa is that you rarely find people who are having like mental health breakdowns in the streets. It's really interesting because I've been to several countries over there, and I've been in the streets in the day and late at night. You don't really see people walking around like zombies on opioids, or people just stripping their clothes off and acting a fool out there. I think there may have been a couple of people begging for change. I mean, I think that's pretty common in developing nations, but I didn't really see Black people out there flipping out like that. I think I see a lot more of that here than I did in my travels. So I find that to be really interesting when it comes to mental health.
Did you know why that is, Mike?
Anyways, why is that?
It has a lot to do with environment, stimulus.
Mm-hmm.
You have areas of Africa. I haven't been to the continent yet, but I am going. You have areas, like in parts of Nigeria or even some areas of South Africa to where there's higher population, per density. But like here in America, you have people stacked on top of each other for decades. It's environmental, not also, looking at the structural racism that is embedded in the fabric of American society. And it hasn't been dealt with, particularly with us, since we walked off the plantation. So, and when we try to have those conversations, get past it. That was 200 years ago. That didn't exist. It didn't happen to you, but it may happen to I think that's one of the reasons behind it. It's environmental. And then two, it deals a lot with the impacts of post-traumatic slavery syndrome.
And we not only also have to deal with slavery, we also have to deal with like what happened after the 60s, the rise of the welfare state, the pushing of feminism and socialism in the Black community. Also the 1994 crime bill as well, because from that, since Biden was senator, the 1994 crime bill has also increased exponentially the stock dividends of the prison industrial complex. That's part of the connection there. And also the environment in which they raise in, like due to lack of mental health care in Dallas and Texas, you have an increase of homeless folks in downtown Dallas along the street and everything, due to the lack of high quality mental health care and physical health care. And Shauna said, that's all by design. Yes.
Yeah, let me finish reading this last paragraph. In line with this year's Black History Month theme, resisting health inequities by addressing the historic and current health and social challenges faced by Black people will be key to achieving health equity. As the Black population continues to grow and become more diverse, improving their overall health and well-being will support the overall health and prosperity of the United States. Yeah, this is true. I think we covered this maybe some months ago, maybe a year or so ago, but Black men not working, cost the United States $50 billion a year. I mean, that's just the tip of it. Not contributing to the economic system through discrimination actually plays a significant role there. So much to be covered. Let me go through this next piece here. Shauna provided this one as well.
So this one, Mike, if I may interject, if you don't mind, this article is very, 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 very long. It's like 125 pages. So I know we don't have time to go through the whole thing, but there's a chart on there that is very profound. And this is up to date. This is from the Pew Research Center as recent as last April.
Yeah, I just want to cover the bolded points. Yeah, this is from Pew Research, as Shauna just stated. Black Americans' views about health disparities experiences with healthcare. Black Americans offer a mixed assessment of the progress that has been made in improving health outcomes for Black people. 47% say health health outcomes for Black people have gotten better over the past 20 years, while 31% say they've stayed about the same and 20% think they've gotten worse. Less access to quality medical care is the top reason Black Americans see contributing to generally worse health outcomes for Black people in the U.S. Large shares also see other factors as playing a role, including environmental quality problems in Black communities, in hospitals and medical centers, giving lower priority to the well-being of Black people. This is true. This is very true. I think we saw that in New York with the brother who was just killed, the one who's doing the moonwalking on the train, the Michael Jackson impersonation. I forget his name now. But anyways, that's an example of how the system has completely spit these people out.
If I might interject, Mike B, you remember that
Yes,
recommended reading I put in the chat? The nutritional destruction of Black people nutricide. Dr. Africa has detailed a lot of the political, cultural, and nutritional factors and environmental factors they point out to that in that book, Nutricide.
Yeah. Yeah. If you get a chance, link it in the chat now. For everybody else who may not know.
I got you.
All right. Yep. Ask about their own healthcare experiences. Most Black Americans have positive assessments of the quality of care they received most recently. However, a majority, 56%, say they've had at least one of several negative experiences, including having to speak up to get the proper care and being treated with less respect than other patients. I think we saw this with Serena Williams, right? This is somebody who had blood clots while she was playing, and she had to have Nike design a special leggings and suit for her to play, so that the blood clots wouldn't be triggered by it. Same thing with her pregnancy, having to see a different doctor or being told off. There's a variety of things, and this is somebody who's a multi-millionaire. Having these sort of problems. We saw a Black woman doctor who last year or something like that during the pandemic who couldn't get access to care or was kind of shunned by her white doctor. She ended up dying. I think that was about a year or so ago. We're seeing these. It's not just socioeconomics that plays a role in this, because if millionaires are having these problems, I can imagine what people at the lower end of the socioeconomic ladder are having. And so, Shawnee, you were going to say something?
Absolutely. It's so true what you say in regards to that, Mike. And I've had a conversation with a couple of people about this, particularly when we look at the Black female mortality rate, particularly with women who are carrying. That's not just limited to women that are poor or middle class. That goes across all economic, strategies. And Serena Williams is one example. Beyonce is another one of the richest women in the world, preeclamptic with twins.
Has access to care.
Beyonce is another one. During her second pregnancy with the twins, she was preeclamptic. Now, this is a woman and her husband who have unlimited resources and was seeing a doctor. So when we have these conversations, the data is out there. We can debate the data all day, but when it comes to certain statistics, those numbers don't lie. There are countless men and women, but the Black female, pregnancy mortality rate, whether that happens during the second trimester, third trimester, or even up to 40 some days after that woman has delivered, it's a reason that it's 4 times the national average, whether she makes $30,000 a year or $280,000. That's structural. That's not just limited finances. Serena is one. Beyonce is another one. There's a young lady, they recently investigated Cedars-Sinai Hospital behind that. I want to say it's Kiera Williams. It made news in 2016, but her husband is Judge Hatchett's, she's Judge Hatchett's daughter-in-law. In prime health, went to have her second baby, died, bled out in the hospital in 2016 because her medical providers ignored the signs of post-delivery complications. This is a woman prime health insured. No reason in this day and age that should be happening at the level that this is happening. That's a health disparity.
You know, there's also another example of the well-known African-American actress Holly Robinson Peete. And she talked about in a YouTube video about the struggles of having certain children of hers that was up to developing autism. How she had to like change certain, you know, health culture in the family to help, you know, counteract it. And then, you know, you look at the famous director producer John Singleton. He passed away at the age of 51 due to a long-standing, you know, battle with like stress and hypertension and, you know, blood pressure.
Yeah.
So like,
let me get to this.
It's not about the economics. It's also about the lifestyle as well.
Yeah, let me get to this next piece that Shauna provided. This is from AAMC.org. My story matters. Diversity impacts healthcare. In this video series, medical students and physicians share their knowledge, backgrounds, and life experiences inspired by their career choice. Yeah, I'm not going to go through all of this because I know there's some slides that we need to go through, but I'll read this one piece here. This is Lee Jones, medical doctor, dean of medical education, Georgetown University School of Medicine, shares how diversity in the public health workforce promotes better outcomes for patients, prohibiting the ability for colleges to consider applicants' racial ethnicity to medical schools would stall progress and hinder our goals to delivering outstanding patient care for all communities. Yeah, this is true. You know, it's surprising enough that the Supreme Court decision comes down and makes this sort of state, you know, decision on admitting students based on their racial makeup and background. You know, I think that's contributing to a lot of these issues. Joelle Burville, fourth year Washington State University, Elson S. Floyd College of Medicine medical student, Joelle Burville, talks about how diversity in medicine is so important to addressing health disparities and why personal stories should continue to be considered in medical school applications. Yeah, you know, these folks don't care, man. Everything's about the culture war for them, and they would much rather, you know, watch. I mean, if you look at, you know, Florida, for example, DeSantis kept, you know, Florida open during the pandemic, you know, didn't shut down not once, you know, and that's somehow a victory, you know, for Florida. And it's, you know, but in Massachusetts, we made people get, you know, people who are traveling from Florida, there was advisories, you know, they had to either been tested or they had to come in with a mask or something like that, you know, off the plane. And so, we kind of put the digital wall up in front of them or a policy wall up in front of them so that they can't actually just come here willy-nilly and just do whatever they wanted. You know, you have to actually check in before you get off that plane. So what's going on, Hamilton? You have something you want to add?
Yeah, I mean, you know, when you look at the infant mortality rate in Mississippi, I mean, it is off the charts how much they do not care in healthcare about things that they should be doing during actual trimesters of pregnancy. Like this, you know, like a friend of mine thought that she had all these major complications with having kids. Like, no, you're just going to Delta Regional Medical Center in King Daughters in order to have these people manage your care. She moved to like Maryland and didn't have a problem. But in Mississippi, she lost like 4 kids, like 4 straight pregnancies. I mean, you know, it had a lot to do with the water down there too. But for these people to be pro-life, they really don't care about these horrific medical outcomes when it comes to Black people, even down there. So.
Exactly. Absolutely. Yeah.
All right, these are some slides that Shauna provided. Let me just kind of squeeze this out here, the comment section. All right. Health equity for Black people in the United States, overall state health system performance for Black people. This chart shows all 50 states, and it shows a median for performance in the 50th percentile. What am I looking at here, Shauna? Because there's a lot of charts, there's a lot of numbers.
So
Um,
just to sum it up, and this came from the, where did I get this from? Because I sent you a lot of stuff, Mike. The link is in the chat. But just to sum up what you all are looking at, this is a updated outlook of breakdown state by state, how healthcare is provided based on ethnicity. And they look at everything from healthcare outcomes to healthcare access, perception. It's very detailed and is up to date. And if you take time to just glance through this, you'll see that the top 3 states that are listed there, Rhode Island, Massachusetts, and Maryland, most of those states are not overwhelmingly African American. Now, Maryland has a fairly nice African American population, even Massachusetts as well. But Rhode Island is not a lot of people that look like us there. And then they also compare it to the U.S. population, where Blacks are currently about 12 to 13% of the U.S. population at about 39 million, it's anywhere between 39 and 44. But the median performance is the basic standard. If you look at this, most states are nowhere near the basic minimal standard of healthcare. And again, this is broken down by ethnicity. This highlights the importance of us addressing health disparities and how much it impacts us. Most of the states where you see your highest African-American or ADOS, or FBA, or whatever we want to call ourselves, population, are way outside of this. So that was one of the reasons why I sent that to you, Mike. I challenge everyone to, in their free time, if they want to review it in more detail. It outlines a lot of good information. And again, it's up to date. This is as recent as 2021, 2022.
I could be wrong, but this CO is Colorado, right? It's not Connecticut.
Yeah,
MOT?
yeah, CO.
Yeah, the
CO is
is
Colorado.
Yeah.
Colorado.
Connecticut is CT.
Can you speak to that, MOT? Like what care was like the VA in Colorado?
No, I mean, we have the largest VA in the actual United States. So it's kind of improper to put like Aurora, Colorado's, which is the VA that I go to. But if you compare it to like VAs out in like Rifle or Lyman, like they're small, then yeah, horrific. But like the Denver metro area, which is like the largest concentration of vets per capita in the United States outside of like Texas for the whole state, we have an excellent $2 billion facility that works on people 24 hours a day and have excellent medical outcomes. But outside of that, it's no different than being anywhere in the Midwest or in the South when it comes to the VA, which is where all the complaints come from, by the way.
Wow.
Yeah,
Wow.
horrific.
Yeah, I mean, the lived experiences, I think that, and match with this data that Sean is providing, I think that this is a conversation that most people in, in this space are not willing to have, not on these other channels. But let me see if I can grab a couple of these slides that Sean has sent earlier. Let's see.
But if they send you
Here
to
we
like
go.
an outside facility to get like additional tests or whatever, it's best that you stay away from the dominant society people in those upper to higher middle class areas. You're not going to get any good outcomes about Black people out there. You're probably going to have to go to somebody Arab or even Latino. I mean, Black if they're even if it's even an option. That's normally how things are handled in that kind of format. So.
Yeah. Yeah, I mean, I think if the United States treated all their major hospitals in the same way they treat the VA in Colorado, I think we would have better outcomes. But
the
this
money goes
slide
towards
right here,
insurance companies. Like the money don't go towards because the insurance companies don't provide health care. They provide roadblocks so that way you can't get care. So for me, I've always said get rid of insurance companies and spend the money on hospitals and do direct payer. I mean, and that's it. That's it. You have this whole roadblock of where the money goes. It just don't go to healthcare.
I would put a cap on it in the same way we have rent control in some states and cities. I'll put a cap on it. No, this person who makes 125% below this, or 65% below this threshold, no, they're not paying anything more than what, than 2% of their income. No, that's incredible for them to pay that much. Anyways, go ahead, Shonda.
Go ahead. Go ahead.
I'm just looking at this slide here that was provided by you. Black adults attribute health inequities to less access to quality care, range of other reasons. Percentage of Black adults who say each is a blank reason why Black people in the U.S. generally have worse health outcomes than other adults. Less access to quality medical care where they live. 63% say it's a major reason, 22% say it's a minor reason, and 13% say it's not a reason. Live in communities with more environmental problems, 52% say major reason, 29% say it's a minor reason, and 16% say it's not a reason. Are more likely to have pre-existing health conditions. 51% say it's a major reason, 30% say it's a minor reason. Healthcare providers are less likely to give advanced care. 49% say it's a major reason, 30% say it's not. It's a minor reason. And 19% say it's not a reason. So more likely to work in jobs with risk for health problems. 47% say major reason. And so when you talk about risk for health problems, essential services, Black people are always on these front lines, doing these high risk, sort of roles, interacting with people that they probably shouldn't be interacting with things they shouldn't be interacting with. I think there was a brother here who actually got electrocuted working for what's the service provider out here? Eversource. I think he had touched one of these transformer boxes, man, and got jammed up real quick, within a few seconds, been stepping out of the truck. So these sort of things play a significant role.
I talked about how in the Midwest, after one of my places had burned down, how they had a whole bunch of people in that actual unit with no type of protective equipment, like tearing down asbestos and all that kind of stuff. I'm like, bro, y'all gotta have all some protective gear out here. And I was like, well, you know what, fam, the money's good and I kind of feel all right, you know what I'm saying? I'm like, oh my God. They got these people out here taking years off of their life, not even using proper people. And they've been paying like probably like $1 million by the insurance company to clean up all that stuff. And those people just refuse to wear protective gear. And it's like unbelievable.
Yeah, you see a lot of Black men doing a lot of the heavy labor work that typically white people just don't do. They just don't interact with, demolition work and stuff like that, washing windows off the side of, 51-story, 60-story buildings and shit.
Yeah,
it's like, cliffhangers, that's what they call them. So cliffhangers. And so, I think there was, there was a Black woman recently. I think there was a Black woman recently who got sucked into a jet engine on the tarmac a few weeks ago.
Yes. Yeah,
unbelievable.
Like down here in Dallas, Texas. Well, I was saying, like down here in Dallas, Texas, most of the people that do be doing a lot of these construction jobs, like the roads and the buildings, is mostly Black men and Hispanic men. I mean, I'd rather see, any white guys doing like the heavy construction work, buildings and roads and that sort of thing. Especially in the metropolitan Dallas area, and especially in the southern part of Dallas County, where there's a lot of, Black folks living at, Oak Cliff, Dunkerville, and City Hill, Minnesota. Nothing but Blacks and Hispanics working on improving roads and buildings. But downtown, most of the high-paying corporate jobs, whites and Asians.
Yeah. Here's another slide that Shawna provided. 40% of Black adults say they've had to speak up to get proper medical care. Percentage of Black adults who say they have ever experienced each of the following problems when dealing with doctors or other healthcare providers. You had to speak up to get the proper care. 13% said yes recently, yes in the past, 27%. The pain you were experiencing was not taken seriously. 11% said yes recently, and 23% said yes in the past. You were rushed by your healthcare provider. Yeah, 9% says yes recently, and 23% said in the past. Felt you were treated with less respect than other patients. 8% says yes recently. 21% says yes, they have that, experienced that in the past. Felt you received lower quality care than other patients. 7% said yes recently, and 21% said yes in the past. I think that I think some doctors who are supposed to be doing good, you know, by their work and by the ethics that they abide by, I think they have an inherent fear of engaging Black people. So they kind of rush them out of the door. Take 2 of these and call me in the morning.
That's true.
I mean, that seems to be a major issue. Like, they don't really want to engage. But how can you, you know, go into healthcare and have that sort of mentality? It just doesn't seem to. It seems to be in conflict. Like, I work in cybersecurity. Like, I can't have this inherent fear of handling someone's data because you know, I might lose it. No, I'm going to play by whatever governance, you know, I have to abide by, you know, in order to provide, you know, the most equitable outcome for each and every user that's in the environment. I just don't understand that logic.
Yeah, I mean, like when my brother had his stroke, like I guess it'd be 2 years ago at this point in time, you're like the level of care. I walked in, I looked at the numbers, I had to call the woman I was supposed to marry before. I'm like, what is this? So it's like, they're trying to kill your brother. Like, no. These numbers are supposed to be this, and this is supposed to be that. He's in the emergency room. I'm like, they're trying to put him in a position to stroke out again. And I had to like bring this stuff up to him multiple times because he was unconscious. He was on a ventilator and all this kind of stuff. And if I was not there, that dude probably would have died. And I had to multiple times, and I had to like, look, well, I'm just going to be in this actual bedroom with them until these numbers start to change. And I had to keep calling her in Memphis, and she'd be like, "Oh, do these numbers look good?" Like, yeah, it's getting better. This is what you're supposed to say to them, all the kind of stuff. Other than that, them people didn't say nothing. Them numbers were super high. They didn't give a damn. They didn't care. I looked at the charts for other people who was on the same wing. None of that stuff looked even nowhere near to where my brother's number one was.
I will just to piggyback on what both of you all have said, it's very deep seated within healthcare. Mike, you raised a very good question a couple of moments ago. Why would someone go into a field like that if that's the issue that they have? Is implicit bias. I'm not defending it at all because there's no way to defend that, but you have to first recognize that you have that in order to address it. And a lot of these medical programs, and even, you know, my background is in nursing. A lot of these nursing programs and allied health programs do not have that built into the curriculum. They started to do it after COVID, but at the crux of it, it's not there. Or if it is there, it's not a mandatory class or training that they have to take. It's offered as a medical elective, or, you know, you may watch a cultural sensitivity video or something along that line, but that doesn't counteract what you grew up in, feeling that you're superior to people that don't look like you, feeling because you come from a family to where your grandfather was a doctor or your great grandfather's name is on the wing of the hospital because they donated X amount of dollars. You can just do whatever you want or have this expectation. I've even seen with my own eyes over the course that I've been in healthcare, don't do this, but I've seen this, to where a patient will tell a provider something, and that same provider will type something totally different in the chart right there in front of the patient's face, which is why it's very important for us to ask questions, get your medical records, I'm always going to be a proponent. If you do not feel comfortable with the person that is overseeing your care or that's responsible for your care, and you have the opportunity to switch, and I know some people may not have that, then switch, because we take an oath as healthcare providers, as medical providers, and we should be held to that standard. It's a lot of superiority complexes within healthcare. It's a lot of egos. It's a lot of, you can't tell me this because I went to, school for XXY, XXYZ, but we have to be more open to being able to listening to our patients. They will tell us what's going on. And if they're not, it's a reason behind that. Maybe out of fear of judgment. Maybe they've had a bad experience. This book has been mentioned in the space numerous times, and I'm pretty sure everybody on the panel, if not in the chat, has heard of it, if not read it. Medical Apartheid by Harriet A. Washington. I strongly recommend that.
I've read that. Yeah.
It's another, we're probably not gonna have time to go over it, Mike, and that's okay, but you linked it in the chat. But this comes out every year. It's through the CDC, through the U.S. Department of Health and Human Services, on the annual perspective of health of the U.S. And it breaks down, all these different health disparities, how this is disproportionately affecting this group versus that group. It's very fucked up. I mean, excuse my French, didn't mean to cuss on your panel.
But when you read
you have a large element of that within the system. One thing that I do see that I think can bring about some change is because we don't have enough healthcare providers here in the US, and with COVID occurring, you did see a lot of the medical programs be a little bit more open to access to different individuals. So currently, and this is on the AAMC's website, you had about 11% increase in Black and African-American applicants and admitted to these medical programs throughout the country. That's a great thing, but most of those are predominantly Black women. We have to do something about increasing that with Black males.
Like what I want to say, interjecting the thing, I remember there was a cousin of mine in Little Rock, Arkansas, named Shonda, that was treated poorly by the medical professionals concerning her treatment for breast cancer. And I came down there and gave a card to them from Rose Law Firm, Mr. Drummond, who's a longtime friend of my mom. And I told him this: the next time you feel like you're gonna mistreat my cousin Shauna, I'm gonna have Mr. Drummond and some friends of mine from the LCLU put a legal suit against you. So either you get it right, or I will talk to your corporate head, medical director, along with my lawyer, see that be replaced. And then they thought I was playing with them, but then when I showed them Mr. Drummond and some well-known ACLU members in Little Rock, okay, he ain't playing. We need to get together. And after that, Shauna was treated a lot better. And what I'm saying is this: we as the people need to learn how to strengthen the political and economic infrastructure in our own community so that we can avoid this. We need to learn how to change our status concerning this civic and legal wise to avoid stuff like that.
Yeah, let me go through this slide real quick, because we got a couple more before we peel up out of here. Top 10 causes of death for Black Americans, 1980-2016. Cause of death in 1980. Yeah, Mr. Cool. Top 10 causes of death for Black Americans, 1980 and 2016. In 1980, the cause of death, diseases of heart, cancer, stroke, unintentional injuries, homicide, certain conditions originating before and at birth, pneumonia and influenza, diabetes, chronic liver disease, cirrhosis, kidney disease. In 2016, the cause of death, diseases of the heart, cancer, unintentional injuries, stroke and other diseases, diabetes, chronic lower respiratory diseases. I wonder if I wonder if the chronic lower respiratory diseases would be attributed to a lot of the menthol cigarettes that were sold in the Black community. I wonder if that played a significant role.
A lot of it does.
Homicide, though.
A lot of that
Yeah,
does with the respiratory. A lot of that does. And then too, it has to do with housing, because a lot of these older homes or residential areas were full of asbestos and lead. Some of them still are.
Yep.
Along with the area in the actual where they live in the city, how they are just allowed to dump pollution or have, you know, like industrial facility zone right next to a housing facility. Yeah, a lot of that stuff still going on across the United States as well.
Yep. Kidney disease, Alzheimer's disease. Now, blood poisoning. I don't know what that means. What does that mean, Sean? The blood poisoning.
Sorry, I forgot to unmute. That one really surprised me. So blood poisoning or septicemia is where you have and situations to where your body is exposed to some type of infection. Either you got a cut or there was some illness that you developed and it was never properly treated, or your body didn't recover from it. And that pathogen or that agent now is in your bloodstream. So I'll just give an example. Say you get a bad cut on your foot. You're not diabetic, or you could be diabetic, and you just treat that with Neosporin. You don't go, get evaluated, or you go get evaluated. They, put you on a little bit of pain medication, anti-inflammatory, but it doesn't fully heal. And that can get absorbed into the bloodstream. Well, if it gets absorbed into your bloodstream, what goes to your heart? Blood. So it can go to different vital organs and make you very, very sick. This is where you see people that are in the hospital connected to all types of tubes, IVs, antibiotics, all types of medications. That shocked me when I saw that, because it's very treatable, but for that to be the 10th leading cause of death of African Americans in 2016, that's asinine to me. But
I guess that would make sense if you're talking about like needle sharing, right?
With needle sharing, you more so are going to see, you may see like, may see some like skin irritation, but with needle sharing, you're more going to see the hepatitis B, hepatitis C, HIV, things along that line. You rarely see septicemia. Septicemia is a pathogen has entered the body. It has not been properly treated, or they didn't recover from it. And now that has gotten into the bloodstream. And once it's in the bloodstream, it can travel anywhere.
Wow. I would like to see the region for that. I have that's my first time hearing about it, but I don't know. That's something I have to look more into. Let me go to this last slide. I'll fly through this really quickly because we don't have a whole lot of time. All right, health, United States 2020 to 2021 annual perspective. U.S. Department of Health and Human Services. Table of contents. Oh man, this is a lot. We don't have a whole lot of time to go through this, but summary of tables.
The data that more so like goes quickly into health disparities and summarizes things up starts around page 11. So you don't have to go through the whole thing, but page 11 going forward kind of outlines the health disparities by ethnicity.
Okay. Page 11. Okay. New diagnosis of human immunodeficiency virus infection by race and Hispanic origin? Wow. Okay, so Black people in 2015 were at 42%, but it's down to 37% in 2019. You know, we talked about this a couple of years ago with Dr. Phoenix, and Dr. Phoenix was pointing out that, you know, STD rates and other transmittable diseases within the military is significantly high. People don't know about it.
Very much so. Yeah.
But you would think in a enclosed environment like that, you know, people would be pretty inoculated from any of these. I mean, who's thinking about getting it in while, you know, if you're in Iraq and Afghanistan? I don't, you know, I don't get it. You know, that's the last thing I'm thinking about,
Mike,
man.
Mike, you'll be pleasantly surprised.
Dudes want to lay down the pipe while they're in the desert, man. Now I'm all set, man. I'm all set.
And then too, you have to look at high stress situations. I mean, one thing being in this industry for 20 years has taught me is people are gonna get it in regardless, whether it's out in 114-degree weather or it could be sub-zero cold. During the pandemic, when folks was at home quarantine, they weren't at home quarantine just sitting on the sofa looking at each other. They was getting it in the house and outside of the house. The stifling thing is, you know, certain things that we thought we had completely eradicated are now back on the uptick, particularly with some of these STDs and STIs. So like with polio was pretty much, you know, eradicated in the 50s, but you're starting to see that's not an STI, but you're starting to see elements of that come back into play. Or like with syphilis.
Well, why is that? Why is polio? Why is polio coming back?
They're like an anti-vax thing. Like
it's an anti-vax element to it. Too, it's a lot of nasty people out here. People do not wash their hands. They do not practice proper hygiene. Now, it's a difference in people practicing proper hygiene if they have access to it versus someone who, you know, is on the street and may not be able to maintain adequate hygiene. But it's a lot of nasty folks out here.
Wow. I mean, you say polio to somebody in the manosphere, they'll think you're talking about like Ralph Lauren, you know, polo. Oh, I got plenty of polo, man. My swag is on, you know, fleet, you know. But in Africa, you know, go ahead.
Go ahead, Mike. I'm sorry.
No, I was just going to say in Africa, I think we covered this during the pandemic that, you know, you saw a lot of innovative contraptions, devices being set up where they had these wash bins outside through, you know, these rain collector barrels where they would actually take these barrels and they converted them into wash bins so that people can wash their hands on the streets and they wouldn't have this issue of spreading COVID or the idea of polio for that matter. And so I find it interesting that, you know, underserved countries, underdeveloped countries can, you know, people on the ground can figure that out. But in the United States, you know, everybody has access to running water, but they can't figure it out. Go ahead, Shonda.
No, I was just going to say, you know, it's it really frustrates me and even pisses me off as a healthcare provider to whereas these statistics, the numbers are so high amongst us. And again, there's multiple reasons for that. But it's the information is out there. We can choose to utilize it however we see fit. I understand there's a lot of distrust and lack of trust within the medical community. I fully understand that. And even as a patient, I have my reservations as a healthcare provider in regards to certain aspects because I've been in the system. I'm not active in the foolishness and the bureaucracy that occurs in the system, but I'm fully aware of the good side of healthcare as well as some of the dark sides of healthcare, because you have to be cognizant of it in order to do what's in the best interest of your patients if you're really sincerely in this to truly help people. Can it be fixed? I definitely think it can. Does there need to be a major overhaul of the United States health system? Yes, it does. This is where it falls on us as individuals, whether we're Black, brown, whatever, and holding not only ourselves, but also those who represent us accountable. Because the reason why it has evolved like this is because healthcare is no longer in the hands of doctors and nurses. It's in the hands of lobbyists, pharmaceutical companies, and health insurance companies. Those are who are making these decisions. Most of these individuals have little to no medical training, but they're deciding on whether or not they're going to pay for a preventative screening exam for you or your brother or your mom. They're deciding on if your medication is going to go from being $10 a month to some insulins, or some medications for diabetes skyrocketing up to $300. Who can afford that on a consistent basis? So I would just, challenge us, do the best that we can with what we have. Try to live our best life, our healthiest life, and then be informed.
What about medical tourism, running down to Mexico, across the border to get some better care, I guess?
So it's, if I were to go anywhere outside the US to get medical care, it wouldn't be Mexico, and that's right down the street from me in Texas. I would go to Cuba. Cuba has one of the best health systems as far as like this side of the Western Hemisphere. Their doctor training is superb. Now, as a country, it has its own, but if I were to seek services outside of the US and I didn't go across the pond, I would look at Cuba. But as far as like going to get a BBL, or if you want to have, plastic surgery and you don't have the funds to pay for it here in the US, or you go to a doctor and they're like, you don't need this, they don't recommend it. You have people that go down to Mexico, but the complications from that, one is typically not regulated. Two, and I did see this working in surgery, if there's anything that goes awry later on, some things are not immediate, and you try to seek medical attention in the US, a lot of these specialists are not going to want to touch you because that's a liability on them. They can't get the records from a lot of these countries. They do not know exactly what was done. It may say you had a gastric bypass and they could did everything but that. So you really have to cutting corners to save money, to look like, a Cardi B or whatever, ain't really all worth that. When you can just go to the gym and do squats and just cut back on your calories, in my view, but I digress on that.
Yeah, same thing for a lot of these brothers with these lace front beards. It's not worth it. Just accept yourself as you are. I guess.
Yeah,
I just want to thank everybody. Yeah. Yeah, thank you all for joining us, man. Shonda, I really appreciate your contributions to this. Mr. Cool, thanks for coming up. MOT, thanks for coming up.
My pleasure.
Thank you. Thank you for